for me. So, yeah, I'm going to talk to you today about the pathway we put into place for vaccine-induced thrombosis. So, my interesting fact for Southampton is that pathology won the Chairman's Outstanding Team Award this year. So every year we have something called Hospital Superheroes or Hospital Heroes, where people across the trust win awards. And this is one of the highest level awards that is available. And I think, you know, celebrating success, it's something that the pandemic has enabled the clinical area really starting to appreciate what pathology as a whole does. And transfusion specific examples were the pathway that I'm going to talk about today, the vaccine-induced thrombosis pathway, electronic prescribing rolling out quickly to enable cancer care to continue seeing their transplant patients, and setting up a transfusion site in one of our private hospitals just across the road from us, which enabled transplantation to continue throughout the whole of the pandemic, which was quite rare, particularly in the first wave. And these are some of the things that the chairman said about pathology as a whole, that we had saved countless lives, that the hospital couldn't have functioned without us, and that we had dogged determination and outstanding innovation examples. Next slide, please. So our UHS Transfusion Team is headed up by our laboratory director, consultant haematologist Dr. Sarah Boyce, supported by Dr. Rashid Kazmi. I'm the TLM. I'm also the chair of the UK TLC, the deputy chair of the National Lab Managers Group, and your deputy chair for this region. We have 3 transfusion practitioners, 2 of which are nurses, John and Diana, and a BMS, Sam Carrington. We have 6 Band 7 senior BMSs dedicated to transfusion. It's 5 whole-time equivalents, but 6 people. And overall, we have 24 BMS staff, some of which rotate through haematology as well, 15 associate practitioners, so Band 4s, and 5 dedicated transfusion MLAs. Next slide, please. And these are some photos of some of our team in action. So you've got Sarah there, you've got the TPs working on a scenario, a simulation, and some of our other colleagues, all of which, you know, we just couldn't run the service without. Next slide, please. So coming on to what we're here to talk about today, vaccine-induced thrombocytopenia and thrombosis, or VITT as it's shortened to. In March 21, we started to see concerns about unusual thrombotic events in patients following the AZ vaccine. And it was kind of characterized by thrombosis at unusual sites, so cerebral venous sinus thromboses. The cerebral venous sinuses drain blood from the dural venous from the brain back to the heart. So we're seeing blood clots there leading to hemorrhage and stroke events. These patients sometimes had thrombocytopenia as well, and often a very raised D dimer and a decreased fibrinogen. Usually they were fit, healthy, young individuals prior to presenting with these thromboses, and they were often between 5 to 24 days post AZ vaccine, and there were some cases associated with other vaccines later on in the course as well. And they had antibodies to platelet factor 4, demonstrated by ELISA technique. The treatment regime for them is anticoagulation and IVIG plus or minus steroid, depending on if they were thrombocytopenic, or plasma exchange for those with the most severe disease. So the rationale behind the IVIG is prevention of antigen-antibody complexes which activate platelets through the Fc receptor. So that's what the IVIG was doing, preventing that. Next slide, please. So for us as a laboratory, we had a call to action when patient 1 presented on the 18th of March. She was a young female, 26 years old, with a cerebral sinus vein thrombosis and thrombocytopenia following AZ vaccine on the 6th. She presented with a headache, photophobia, and nausea, and was proven to have a cerebral sinus vein thrombosis. And there's a few of the other cases we had listed here just to show sort of the range. So we had a 70-year-old female with deep vein thrombosis, so not quite the same. She also had a PE and thrombocytopenia, and she was 2 weeks post-vaccine. Another young lady, a 29-year-old female, presenting with headache, confusion, and seizures 10 days post-vaccine, who had a cerebral sinus thrombosis and actually required intubation on ITU. A 45-year-old female who's 14 days post-vaccine. So you can see the sort of differences in the date post-vaccine and the ages. In total, we had 11 confirmed patients, ranging in age from 26 to 70, and we had 2 deaths in that patient group. One of them was a 55-year-old lady and one of them was 43, and they were all females. Our requirement for screening for this test went from about 10 a month to about 10 a week during this period, where we were seeing lots of worry, lots of concern as it hit the news for these cases. Next slide, please. So what did we need? We were seeing this increasing concern. We were seeing these very young patients affected who were fit and healthy before. So what we really needed was fast clinical review from our specialist team, Sarah and Rashid, and a way to make differential diagnoses and treatment decisions. So we were lucky that we already had a validated method to run the ELISA for HIT screening. So it's the same antibody, the anti-PF4 antibody seen in heparin-associated thrombosis as well. Sorry, so we were looking for the high titer antibody to platelet factor 4 in the serum, and this antibody to platelet factor 4 activates the platelets, and this is in the
PML, whether she accepts blood or not, it's a very serious.
Sorry, there's someone talking in the background. So in this case, it's in the absence of heparin in the VITT patients. Interesting to note that there was a list of approved techniques. So some methods gave falsely negative results. So you would be unable to use AccuStar as a screening method for VITT and some of the other ELISAs. The other thing that was asked of us was to help the emergency departments, which were becoming overwhelmed with patients presenting with a headache post-vaccine. So it hit the news. Young females, people were worried. Headache was one of the common symptoms post-vaccine anyway, and some emergency departments started to become overwhelmed with patients showing up with a headache post-AZ vaccine. Next slide, please. So what did we do? So we were, as I said, we were already running the validated method for HIT screening with a 3-hour turnaround time, 9 till 5, Monday to Friday sort of service. So almost overnight, immediately, we increased that service provision to 1 to 7 days with a service of 8 a.m. till 8 p.m. and the ability for us to come in overnight if it was really clinically needed as well. It was a voluntary roster covered by the senior staff that I mentioned earlier. They volunteered their time to be on call to come in and do these tests. And we worked together in the region, so we offered this test to neighbouring hospitals where it might be quicker for them to send it to us rather than to the NHSBT reference centres. We also took part in a regional piece of work which was led by the CCGs to develop a pathway to ease pressure on the emergency departments, but still enable urgent decision making and urgent treatment for those patients who were highly likely to be suffering from VITT. Next page, please. Next slide, please. This is just as a snapshot of the treatment regime for the patients that we saw that was designed by Sarah and Rashid. And you can see in the box there where the lab came in, whether the HIT screen was positive or negative, and then what the treatment decision would be for that patient. So when they came in, they had a barrage of tests. They were started on anticoagulation. They were given prednisolone if they were thrombocytopenic. They had their HIT screen. If it was positive, they were started on IVIG. And if it was negative, it was likely not vaccine provoked. There were standard treatment pathways, but the haematologists were available should there be a real clinical suspicion that we were still looking at VITT. Next slide, please. So there's some take-home facts for you here from Sue Pavard's group and a publication in the New England Journal of Medicine. So Sue Pavard was part of the expert haematology group who reviewed all of this data, and this data is from probable or definite VITT diagnosis cases as of the 6th of June this year. So at that point, we'd given 8 million first doses of vaccine to patients who were less than 50 years old, to put this into perspective a little bit. And we'd had 141,000 UK COVID-19 deaths. So, you know, the vaccine was incredibly important in the UK's approach to getting out of the COVID pandemic. Within those 8 million first doses, we saw 220 cases of it with 49 deaths, and 85% of those patients were less than 60 years old. So it is a rare complication, but it is a devastating complication associated with extensive thrombotic events. And what was found was that patients who had the low platelet count, low fibrinogen, and increased D-dimer were associated with a worse outcome. And those are the patients that perhaps we should be considering plasma exchange. Next slide, please. So thank you for listening. Do you have any questions?